Ladies and gentlemen, hello everyone. Greetings from Suzhou, China. Good day to all of you. I'm Jaco. I'm the host today. On behalf of RainMed, we welcome all of you to participate in our webinar. RainMed had several webinars successfully in the first half of 2020, which attracted hundreds of doctors, physicians, and medical device distributors from different countries and regions. The webinar will provide you a more accessible, more convenient platform to communicate directly and share state-of-the-art knowledge of healthcare. We've had heated discussions on the emerging technologies and clinical trials in the area of interventional cardiology. RainMed is always dedicated to bringing healthcare innovation and making a great difference to people's lives. The caFFR system is featured as accurate diagnosis rate, adenosine and guide-wire-free, providing a faster-paced, economical, precise approach for doctors to diagnose the coronary artery stenosis. Positive feedbacks and appraisals from different hospitals have given us more determination and confidence to make FFR system available to people who are suffering from coronary artery diseases. Today, we have the very pleasure to invite Dr. Chandan, a member of the Royal College of Physicians of England, Bachelor of Medicine and Bachelor of Surgery, currently working as a fellow of Dr. Alan Fong in training from Department of Cardiology at Sarawak Health Center in Malaysia to share us his practices on wire-free FFR in percutaneous coronary intervention. Dr. Chandan now focuses on intervention cardiology. The Sarawak General Hospital is the largest hospital in the state of Sarawak in Malaysia. It is also the main tertiary and referral hospital in East Malaysia. During the presentation, if you've got any questions, please kindly leave your messages in the live chat. We'll collect them and later they will be answered. Now let's welcome Dr. Chandan. Over to you, Dr. Chandan.
Hi, good afternoon. Thank you very much for the warm introduction. My name is Chandan, as mentioned. I'm a interventional cardiology fellow here at the Sarawak Heart Center. So I will be presenting to our audience members on the utilization of wire-free FFR in PCI in our practice in the cath lab. So caFFR provides a novel wire-free FFR technique. It was developed by the RainMed team over at Suzhou, China, which I'm sure most of you all are aware of. It utilizes computational flow dynamics with angiography and real-time aortic blood pressure. It does this in order to determine FFR without the need of an invasive wire or a hyperemic stimulus. So majority of the data for the caFFR system comes from the FLASH FFR trial in 2019 by Lee et al., which demonstrated a diagnostic accuracy of just under 96% for all values. It also showed a very high sensitivity and specificity of 90 and 98% respectively. The caFFR also uses a cutoff, which is the same as the wired FFR, which is that of 0.80. So I will demonstrate a few cases in how caFFR has assisted us in our practice. So the first case is a patient in which the caFFR system was able to guide us to defer PCI. We have a 27-year-old male who is a smoker and a diabetic. He has a history of an inferior STEMI, which was successfully thrombolized in one of our district hospitals last year. So this gentleman on presentation to us had a normal resting echo with a preserved LV ejection fraction. We then proceeded with his coronary angiography, which showed a normal left coronary system. But as you can see, he has about a 60% stenosis in the mid-RCA segment. So in this gentleman, we decided to perform a caFFR. Now, if you see, there is a significant anatomical stenosis in this patient. There's an anatomical stenosis of at least 50 to 70% based on the software. However, the FFR calculated down the RCA is non-significant, and the patient's caFFR down the RCA was 0.87. So now in this young patient who was currently asymptomatic at the time of angiography with a negative caFFR, we decided to medically manage this gentleman. No intervention was performed. We then called him a month and subsequently 6 months later, and he was NYHA1 and had no angina whatsoever. Case number 2 is also a patient in which we used the caFFR system to defer PCI. Now, this gentleman is a 49-year-old male who has a history of type 2 diabetes mellitus, hypertension, and dyslipidemia. He was admitted in October 2019 with a non-ST elevation MI with acute pulmonary edema. His resting echo demonstrated a normal LV ejection fraction, and he had no regional wall motion abnormality. So we did a coronary angiogram for this gentleman, which again showed a single vessel coronary artery disease, and he had a proximal LAD stenosis of 50 to 60%. So in this gentleman, we performed a caFFR as well. And as you can see, the caFFR was negative. It came back as 0.89. But in this patient, because it was the proximal LAD, the patient was quite young, and we were dealing with a potentially prognostically significant lesion, we decided to perform a wired FFR. So after giving intracoronary GTN and achieving maximum hyperemia with adenosine, we performed a wired FFR. And as you can see, the wired FFR with hyperemia was 0.89, which is identical to the caFFR. Thus, in this patient, no PCI was performed either, and we decided for medical therapy optimization. Case number 3 is that of a patient in which we used caFFR to treat a tandem lesion in one of the coronary vessels. So we have a 62-year-old gentleman who is a dyslipidemic. This patient had initially presented with stable angina and had a positive exercise stress test at a private clinic. His resting echo, however, was completely normal. We performed a coronary CT for him, which showed a very high calcium score and multiple dense calcium deposits in the proximal LAD. So when we performed the coronary angiography for this patient, we noted 2 discrete lesions in this patient's LAD, one of about 80% stenosis in the proximal LAD, and one of about 60% stenosis in the mid-segment. His circumflex and RCA artery were normal otherwise. So now in this patient, because he had two lesions, we wanted to get some physiology to decide how to proceed further. So we did a caFFR down the LAD, which came back to be highly suggestive with a caFFR of 0.67. Now there was a drop between the proximal and mid-LAD lesion as well. So our initial aim of treatment in this gentleman was to treat the proximal lesion first and then reassess the situation at a later time. So we proceeded with PCI to the proximal LAD. We pre-dilated the lesion with a NC and subsequently NSE alpha balloon, and then used a create stent up to 10 atmospheres of a 3 millimeter stent size. We then post-dilated the proximal stent with a 3.5 NC balloon. So at this point, we decided, we looked at the angiogram and it looked quite good, albeit there was that focal mid-LAD stenosis as well. So we decided to do another caFFR. And now the caFFR has gone up from 0.67 initially to 0.90 now. So that mid-LAD lesion has become no longer significant. So in this gentleman, no further intervention was done, and we decided for medical therapy. So we were able to defer PCI for the second lesion, which we may have potentially intervened. Case number 4 is a patient in which caFFR helped us in the deployment of a drug-coated balloon. We have a 52-year-old male smoker who is a dyslipidemic. He was admitted to one of our district centers with an anterior stent last year. His echo post AMI showed a mildly reduced ejection fraction of between 40 and 45%. So his coronary angiogram also showed single vessel coronary artery disease with two lesions, one significant lesion in the osteoproximal LAD territory and also one in the mid segment. So we performed a caFFR down the LAD, which was very low, which was 0.54. So because it was highly suggestive, we felt both lesions needed to be treated. So we decided to treat both the proximal and the mid LAD lesion. We initially used a 2.5 semi-compliant balloon. Subsequently, we noted very good opening of the vessel with only 20% recoil, and TIMI-3 flow was maintained. So we repeated a caFFR down the vessel. And as you can see, after we repeated the caFFR, it has gone up from 0.54 to 0.83. Thus, we've gone from a significant FFR value to a non-significant value. So we were rather pleased with this result. So we decided for a DCB strategy for both the proximal and the mid LAD using a 3.0 DCB in the proximal LAD and a 2.5 DCB in the mid LAD. As you can see, his final angiogram shows a very good result, albeit there is a type B dissection in the mid LAD, but because TIMI-3 flow was maintained, we decided to leave it alone. Case number 5 is a patient in which we used caFFR to reinforce the need for bypass surgery. We have a 51-year-old male from one of our district centers who is a hypertensive diabetic dyslipidemic. He has a history of an inferior STEMI in 2018, which was thrombolized with intravenous streptokinase. So his index angiogram in 2018 shows quite severe triple vessel disease with multiple stenosis in the LAD, and occluded circumflex, and multiple stenosis in the RCA. So this patient's resting echo was completely normal on arrival here as well. So this gentleman who is a type 2 diabetic with preserved LV ejection fraction was subsequently referred for a CABG as per ESC guidelines. So he was seen in late 2018. However, due to our waiting list for open surgery, his tentative date for surgery was only in 2020. And because the patient was fairly asymptomatic at that time, he was happy with medical therapy and didn't mind waiting. So when we reviewed him in January this year, he was completely asymptomatic and he had no chest pain. And this is why he was not keen for surgery anymore. And he was very happy with his medical therapy at this point. So the surgical team discussed with us for a repeat angiogram to see if the patient could be taken off the surgical wait list as he was currently asymptomatic. However, his repeat angiogram looked fairly similar to the index angiogram in 2018, with multiple stenotic segments in the LAD artery, along with the occluded circumflex and the multiple stenosis in the RCA. So we did a caFFR down the LAD artery again, and as you can see, it is significant, with a caFFR of 0.73. So now in this patient, because he was being referred back to our surgical team, we decided to do a wired FFR for comparison as well. So the resting PDPA was 0.84. And after giving the patient adenosine and achieving hyperemia, the FFR dropped to 0.67, which is also significant, similar to our caFFR result. Now, this gentleman has had no events since his AMI, and his angiogram shows very similar disease with no disease progression at all. However, his FFR and his caFFR both suggest a very significant LAD. So he was referred back to surgery. His CABG was subsequently performed on the 1st of March this year. And when we followed him up at 1 and 6 months post-procedure, he was well with no active complaints. My last case for presentation today is that of a patient in which we had some discrepant values between the caFFR and the wired FFR. So we have a 61-year-old male who is a hypertensive dyslipidemic. He has a history of myocardial infarction in 2014, during which time we did a PCI to the circumflex artery. He then presented in 2017 with stable angina, during which time a PCI was performed to the LAD. Post-procedure, his ejection fraction was 30%. He was admitted this year with unstable angina. So we decided to do an angiogram for this gentleman, and his circumflex stent was patent. His LAD stent was patent as well. However, we did notice a little bit of a stenotic segment after one of his LAD stents. it looked like it was between 40 and 50% on angiography. We thought that this may or may not be significant, so we decided to use some physiological assessment in this patient as well. So from another view, again, it looks significant in certain views, but in other views, it looks okay. So when we did a caFFR for this patient, the caFFR came back to be 0.77, which is significant. However, on looking at the angiogram, because it was showing us a discrepant result with the angiogram, we decided to do a wired FFR. And when we did a wired FFR after giving adenosine, the FFR was 0.86, which was not significant. We then decided to accept this result and decided for medical therapy for the LAD lesion. We then reviewed him back a month later, and he had no chest pain, and he was NYHA class 1. So in conclusion, the caFFR offers a novel method to aid decision-making. It does this without having to accept the risks of an invasive wire. It seems to be fairly accurate in most cases. However, more data and follow-up will be needed to determine its eventual clinical utility. caFFR does have some limitations. There is some significant discrepancy noted in patients with a poor LV ejection fraction, as illustrated in the last case. And invasive FFR may be considered, especially in this scenario with a gray or discrepant reading. caFFR also relies on good angiographic projections with as less overlap as possible in order to allow for adequate and accurate vessel mapping. And we are not sure of the utility of caFFR in acute myocardial infarction, as they were not recruited in the initial trial. So how has our experience in the Sarawak Heart Center been so far? So since having this software from the RainMed team, we've been able to interrogate 78 vessels to date. We've been able to defer PCI in 18 vessels so far. And when we reviewed them at all the way up to 6 months post-procedure, none of our patients had any target vessel revascularization or major adverse cardiac events. However, this data is fairly premature, and we need more patient data and follow-up to be able to go further with this. Thank you very much.
Thank you for Dr. Chandan's sharing. It certainly gives us a better perspective on the advantages of wire-free FFR in practical cases. Right now, we will take a short 10 minutes break, during which period you are welcome to leave any comments on the live chat. And the comments and the questions in the live chat, we'll have them answered by our team and Dr. Chandan later. Thank you. We'll take a 10 minutes break now. Thank you.
Thank you.
Hello, is that Dr. Mark Lekose?
Yes, right, that's me.
Hi.
Hello, John.
Yes, hi, please go ahead.
Yeah, I just would like to hear your comments and thoughts about the discrepancy we saw in the last case. And also the question mark for AMI patients.
I'm not the best person to answer that. Actually, we have been keep a very good communication with the Alan Fong and Chandan. See that so if there's a discrepancy about the left ventricle LVAF, or if there's any patients about that, usually with the good image or good exposure of the vessel, we can have a pretty accurate result. But yes, if there's can be some picture to showcase why, for example, like why the LVEF would show a discrepancy, and that would be greater. So
I think in our in our practice in patients, firstly with reduced LV ejection fraction, we postulate that because in poor EF, as you're injecting the contrast into the coronary artery, maybe it doesn't opacify the artery as well as we want. And that might show a falsely lower result than the wired FFR would. But we've only had this experience with low ejection fraction for a few cases. So I think we need to continue on with it for a while. But we think that's the reason behind it. Mm-hmm. And with regards to the acute myocardial infarction, actually in the index trial, they did not recruit patients with AMI. But in our practice so far, we do use patients with AMI, and it seems to work quite well.
Wonderful. Thank you very much.
Mm-hmm. Yes, we will be interested to see if there could be some improvement about the image and improvement about calculation of the caFFR. Is the Bob here or Jaco? Oh.
Yes, I'm here.
Yes, hi. So can you record it down so that we can keep this follow-up about the discrepancy about that? Yeah.
Yes, I will keep noted of this question.
All right. Yes, that would be very interesting. And we're looking for so Dr. Saplantaris. So have a question, Dr. Panos.
Yes, hi. I would like to ask if you use a pump for injecting contrast, like the assist pump, or do you use hand injections, and whether this might influence the measurements of caFFR?
Sorry, would you like me to answer this question?
Yes, please. Thank you.
Oh, sorry. Sorry about that. So in our practice so far, we use hand injection, and we find as long as we can get a clear opacification of the artery, and as long as there's no overlap in the vessel itself, we get a fairly accurate caFFR.
Mm-hmm. I think that we can propose a paper to show that there might be only 5% difference in the different injections approach. So
right.
So in our last clinical trial, we have the size both use both the hand injection and the pump injection.
Okay, great. Thank you.
Thank you. Yes, there were some interesting questions too regarding that the caFFR. We have been accumulating the cases and to see any good use, or can be some expanded use in the multivexel, in the different use besides the stable angiography. Oh. Okay, Taro also answered some of the questions. Yes, Jaco, please hand it back to you.
The answer to Dr. Panos' question, Taro, the exposure of about 4 ml per second to push the injection of the contrast agent. I hope that solves your question, Dr. Panos.
Yes, thank you very much.
Thank you. Any other further questions from our attendees today? You can leave them in the live chat. I have a comment from Dr. Alan Fong. He said, with the right views, including minimizing any overlapping vessels, where stand good angiographic image will be able to enable the caFFR to be easily and rapidly generated. Meanwhile, we will send you our questionnaire link in the live chat box. We'll appreciate if you could take some time to fill it in. Hello everyone, we are doing the questionnaire I have sent you the questionnaire link in the live chat. Please kindly take several minutes to fill it in. It will benefit us to provide you some comments and feedbacks later. Thank you very much. Hello everyone. The questionnaire will be closed in 2 minutes. If you have any questions and issues about, or you want to understand our technology, please kindly follow our website and our LinkedIn profile. And today we have our sales manager, Miss Riching and Miss Lisa. And they will have these questions or your comments gathered. If you have any intention for the knowledge, we'll have them answered.